Picture a young, elite athlete. I mean, someone at the absolute peak of human physical fitness.
Right.
The stadium is roaring around them, the lights are blinding, and they are moving with a speed and a grace that seems, honestly, almost superhuman.
Oh, absolutely.
And then suddenly, without warning, without any physical contact from another player, they just collapse on the field.
Yeah.
The crowd goes dead silent, the medical team rushes out, and time just seems to stop entirely.
It's terrifying.
It really is. And I really want to unpack this today, because this specific scenario represents what has to be the ultimate paradox in modern medicine.
It is a profound paradox.
Right. How can the absolute healthiest individuals among us, the ones who eat perfectly, who train relentlessly, who easily pass every basic physical harbor, a hidden, fatal flaw that strikes completely out of nowhere?
And the really wild part is that the very act of pushing the body to its limits can actually be the trigger itself.
Exactly. And more importantly, how are today's top medical detectives figuring out exactly who is at risk before it is too late?
Well, today we are decoding the ultimate engine, which is the athlete's heart. We're going into the absolute cutting edge of sports cardiology, and we're going to uncover the incredibly razor-thin line between peak physiological adaptation, where the heart becomes an optimized supermachine, and deadly pathology, where that exact same machine suddenly and catastrophically fails.
But before we jump into this deep dive, we want to give a special thanks to London Heartbeat Z Academy UK for their educational support of this discussion. We highly request you, our listeners, to explore its more than 200 popular courses. Make sure to subscribe to their social media on Facebook, Instagram, and YouTube for free, regular updates so you do not miss future amazing discussions. Also, consider subscribing to their higher level of YouTube membership for early access to educational videos and even to have personal chats and guidance sessions.
Yes, definitely check them out.
So our mission today is very clear. We are analyzing an incredibly extensive, brand new 2026 primer on sports cardiology.
It's a massive document.
It is. We are going to explore the 6 fundamental domains of cardiovascular care in athletes. We will unpack the reality of sudden cardiac death, decode the complex electrical and structural changes inside an athlete's heart, and learn exactly how cardiologists manage high-risk athletes to keep them safe.
While still keeping them in the game, which is the ultimate goal.
Right, exactly. So let's just take a breath and dive right into the first domain.
Sounds good. So if we step back and connect this to the bigger picture, sports cardiology truly sits at a very unique, highly specialized intersection. It's the exact point where preventive cardiology meets high-performance athlete care.
Right, because usually those are two different worlds.
Exactly. Now, on one hand, we have decades of incontrovertible data proving that regular exercise is practically miraculous for the human body.
Oh, for sure.
It dramatically curbs atherosclerosis, which is, the gradual buildup of fats and cholesterol in your artery walls, and it reliably increases overall longevity.
But there is a catch.
There is a big catch. On the other hand, vigorous, intense exertion can sometimes act as an acute stressor. It can unmask latent, hidden cardiac diseases and actually precipitate sudden cardiac death.
Especially in individuals who have a genetic predisposition that they might be, well, completely unaware of.
Right. And the societal impact of this is just massive.
It really is. Because, when an older person with known long-standing heart issues passes away, it is obviously a tragedy. But it kind of fits our accepted mental model of how the world naturally works.
Yes, exactly.
But sudden cardiac death, which I know you guys abbreviate as SCD in a young, vibrant athlete, it entirely shatters that mental model.
It does. Now, statistically, as we were reading through the source material, the incidence is actually quite uncommon. We are looking at about 1 in 50,000 athletes.
Okay, so 1 in 50,000.
Right. But because it is so incredibly counterintuitive, it has this profound, rippling psychological impact on families, on the sporting community, and really on the public at large.
It forces everyone watching to ask, could this happen to me? Or could this happen to my kid out there on the soccer field?
And that psychological impact is exactly why risk stratification is the absolute cornerstone of this entire field of medicine. We have an obligation to figure out exactly who is in that vulnerable 1 in 50,000 demographic.
Right.
And to do that effectively, we first have to understand that the risk is not distributed evenly across the population, not even close.
It's heavily influenced by demographic factors.
And heavily influenced.
Right. And to really ground this for you listening, I want you to imagine a practical case right out of the gate here.
Good idea.
Think of an 18-year-old black male basketball player. Let's say he is getting ready for his freshman college season.
Okay.
He feels perfectly fine. He has never been dizzy. He has never had chest pain. He has never fainted. He's running miles every single day without breaking a sweat.
Typical elite athlete.
Exactly. But, like all college athletes, he is required to undergo a routine medical screening before the college season officially begins. So, if you are the cardiologist looking at his intake file, what are the demographic alarm bells that are ringing in your head before you even pick up your stethoscope to listen to his heart?
Well, in that specific scenario, the demographic data alone tells a crucial, highly statistical story.
What does the data say?
It says that adolescent and young adult males who participate in dynamic sports of a start-stop nature, think basketball, soccer, tennis, are inherently at the highest risk for sudden cardiac events.
Okay, let's break down those numbers because I know they are striking.
They really are. Simply being an adolescent male gives you a 6-fold greater risk of experiencing sudden cardiac death compared to a female athlete of the exact same age.
Wow, a 6-fold increase just based on being male.
Exactly. But it compounds. When we look at an 18-year-old black male athlete participating in those start-stop dynamic sports, he has a staggering 20-fold greater risk than a white female athlete.
Right, 20 times.
Yes, a 20-fold greater risk. This raises an incredibly important question about why this disparity exists.
Is it genetics or the sport itself?
Some of it is genetic, some of it relates to the specific demands of the sport, but from a purely clinical diagnostic standpoint, the immediate application is that risk stratification must, without exception, begin with demographic awareness.
Okay, so we know exactly who is most at risk. Do we know what is actually causing the heart to stop in these young kids? Like, what is the actual mechanism breaking down?
We do. But the etiology, which is, the medical term for the root cause, varies significantly depending on both the region of the world the athlete is from and their age.
Okay, let's talk about age first.
For athletes under the age of 35, the culprits are almost always one of two things. First, inherited cardiomyopathies, which are genetic diseases of the heart muscle tissue itself.
Right.
Or second, primary arrhythmia syndromes, which you can think of as essentially electrical short circuits in a heart that otherwise looks structurally perfect.
And the geography of this is wild to me.
It is fascinating.
Because if you look at the data from the United States, something called hypertrophic cardiomyopathy, or HCM, is the leading reported cause of sudden cardiac death in these young athletes.
Yes, HCM is massive in the U.S. data.
And from what I understand, HCM is where the heart muscle just becomes abnormally thick, right?
That's correct. The muscle wall, usually the septum dividing the left and right sides of the heart, thickens excessively due to a genetic mutation.
And that causes problems.
Huge problems. It disrupts the heart's ability to pump and sometimes triggers lethal electrical rhythms.
Right. But then you fly over to the Veneto region of Italy, and their data points to a completely different disease called arrhythmogenic cardiomyopathy as the most common cause.
Exactly. The regional variations are very real.
And then in the UK, the specialist cardiac pathology data reveals something even more baffling to me.
The structurally normal hearts.
Yes. In 42% of sudden cardiac death cases in young athletes in the UK, when they do the autopsy, the heart is structurally completely normal.
Which points directly to those primary electrical or arrhythmia syndromes we just mentioned, like sudden arrhythmic death syndrome or SADS.
So the heart itself isn't broken.
Well, not mechanically. In those 42% of UK cases, the physical engine, the valves, the muscle walls, the plumbing looks absolutely perfect under a microscope.
Wow.
But the software running the electrical timing just crashed irreparably.
Now, a quick clarifying question on the age cutoff. We said under 35 is mostly genetics and electrical software glitches. So for athletes over 35, does the risk profile completely flip?
Yes, it completely flips. Once an athlete crosses that 35-year threshold, coronary artery disease takes over as the overwhelming predominant cause of sudden cardiac death.
So just standard plaque buildup.
Exactly. This is the classic plaque buildup in the arteries that we traditionally associate with heart attacks in the general public. And yes, it is the leading cause, even in individuals over 35 who run marathons and eat perfectly.
Okay, I want you to put yourself in the shoes of a cardiologist for a second. Let's make this an interactive question for you listening.
I love a good quiz.
If you had to guess which sport is the absolute most dangerous for a teenager's heart, what would you pick? Most people would assume it's running a marathon, right? Let's make it a multiple choice.
Go for it.
Time for a quick quiz. What type of sport poses the highest risk for sudden cardiac death in young athletes? Is it A, steady-state endurance sports like marathon running, B, dynamic start-stop sports, like soccer and basketball? Or C, high-static sports, like powerlifting and weightlifting?
Well, the correct answer is B, dynamic start-stop sports.
Why is that?
What is fascinating here is the underlying physiology of why this happens. When an athlete transitions instantly from standing completely still, say, a soccer player waiting for a pass to a full explosive sprint, the physical and metabolic stresses placed on the heart are immense and instantaneous.
Right, because everything suddenly fires at once.
Exactly. The sympathetic nervous system, your fight or flight response, triggers a massive sudden surge of adrenaline and catecholamines into the bloodstream.
So it's not the steady exertion that's the problem, it's the sudden jolt. It's like taking a car that's idling at a red light and just slamming your foot on the gas pedal to the floor. The engine mounts take a massive shock.
That is a perfect analogy. These sudden burst exercises act as incredibly potent triggers for any underlying cardiac issue. The sudden flood of adrenaline can irritate a hidden electrical flaw, increasing the relative risk of sudden cardiac death in affected athletes by 3 to 5 times compared to their peers who are just sitting on the couch.
Okay, let's take a quick breather before moving to the next section.
Sounds good.
So, we know who is at risk, and we know exactly what sports act as the trigger. But here is where it gets really frightening to me.
The silent nature of it.
Yes. The primer notes that over 80% of athletes' sudden cardiac deaths occur directly during physical exertion. And in the vast majority of these cases, the tragic cardiac arrest itself is the very first symptom the athlete ever experiences.
And that is the silent threat we are dealing with. In sports cardiology, relying on traditional medical histories and standard physical exams, like simply listening with a stethoscope, has a notoriously low diagnostic yield.
Wait, why is a stethoscope so bad at catching this? I thought that was the whole point of a physical.
Well, a stethoscope is designed to hear the mechanical closing of valves and the turbulent flow of blood, what we call murmurs.
Right.
But most of the cardiac diseases implicated in young sudden cardiac death, especially the electrical ones, do not produce any audible murmurs or physical signs. A software glitch in the heart's electrical system doesn't make a sound.
That makes total sense.
There are rare exceptions, of course, like Marfan syndrome.
Oh, I've heard of that.
Yeah, that is a connective tissue disorder that can cause the aorta to balloon out and rupture. And it often presents with a very distinct physical appearance. Patients are usually very tall, thin, with exceptionally long arms and fingers.
So you can actually see that one.
Exactly. But for the vast majority of these conditions, listening to a young athlete's chest with a stethoscope and asking if they feel okay is simply not enough to catch these lethal conditions.
It is literally like waiting for the smoke alarm to go off after the house has already burned down to the foundation.
That's a grim but accurate way to put it.
If the very first symptom of the disease is sudden death, we obviously cannot wait for symptoms. We need preventative sensors. We need a way to look inside the wiring of the house before the short circuit happens.
And that preventative sensor is the 12-lead electrocardiogram, or ECG.
Okay.
The European Society of Cardiology, the ESC, strongly endorses a preparticipation screening protocol that includes a comprehensive health questionnaire paired with a resting 12-lead ECG.
And what does the ECG actually do?
The ECG is highly sensitive. It gives us a real-time, multi-angled map of the heart's electrical depolarization and repolarization waves.
Meaning it tracks the electrical signal that tells the heart muscle to squeeze, and then the signal that tells it to relax and recharge.
Precisely. And by mapping that, it allows us to spot electrical diseases like long QT syndrome. That's where the heart takes too long to electrically recharge between beats, making it vulnerable to short-circuiting. Or Wolff-Parkinson-White syndrome, where there is an extra abnormal electrical pathway that bypasses the heart's normal speed limit and can cause runaway, incredibly fast heart rates.
It's basically finding the faulty wiring.
Yes. Crucially, the ECG is also incredibly effective at identifying the subtle electrical anomalies that hint at underlying structural cardiomyopathies long before the muscle itself has grossly deformed enough to cause symptoms.
And we know for a fact this works because we have a real-world nation-sized case study, Italy.
Ah, yes, the Italian data is incredible.
Right. Italy actually mandated ECG screening for all competitive athletes way back in the 1970s. And over a 30-year follow-up period, they rigorously tracked the data. By utilizing the 12-lead ECG and a limited exercise stress test, they reduced the incidence of athlete sudden cardiac death by an astonishing 90%.
It's unbelievable.
They took the rate from 3.6 deaths per 100,000 down to just 0.4 per 100,000. That is thousands of young lives saved over decades just by attaching a few stickers to a chest and reading the electrical waves.
It is a phenomenal public health achievement, and it proves the efficacy of the tool.
Hmm.
However, we also have to acknowledge the limitations.
What are the limitations?
Well, the ECG is not magic. Because it is fundamentally an electrical test, it will inevitably miss up to 20% of conditions that don't primarily affect the resting electrical system.
Like what?
For example, it often misses early coronary artery disease, specific types of aortopathies where the blood vessel is enlarged but the heart muscle is fine, or very isolated, tiny patches of myocardial scar tissue.
And historically, the pushback against ECG screening in the U.S. was always about false positives, right?
Huge pushback, yes.
Critics would say, look, if you screen every high school kid in America, you're going to get tons of weird ECG readings. You'll falsely diagnose thousands of healthy kids with heart conditions. You'll ground them from sports unnecessarily, causing huge emotional distress. And you'll bankrupt the healthcare system with expensive follow-up MRIs to prove they are actually fine.
Yes, that was the standard argument for a long time.
But based on the 2026 data we are reviewing, that argument is getting pretty outdated, isn't it?
It is very outdated. The field has evolved tremendously over the last decade. We now have highly refined, standardized international recommendations for ECG interpretation specifically tailored to athletes.
So the doctors are just better at reading them now.
Exactly. By doing massive population studies and deeply understanding what a normal athlete's heart looks like on an ECG, we have successfully reduced false positive rates to just 2 to 3%.
That's a huge improvement.
It really is. And we achieved that without compromising the sensitivity or specificity of the test. We can now confidently filter out the physiological noise of a healthy, trained heart from the true pathological danger signals.
Okay, let's make another bet here, putting you listening in the hot seat again.
Let's do it.
Listener, let's test your knowledge on screening. What percentage of sudden cardiac deaths in athletes happen during physical exertion? Is it A, 30%, B, 50%, or C, over 80%?
The answer is C, over 80%.
Over 80%.
Yes, and this statistic is exactly why preparticipation screening is so incredibly vital. The exercise itself is the metabolic and adrenergic trigger that pushes a vulnerable, previously quiet heart over the edge into a fatal arrhythmia.
Right.
If we don't screen them in a quiet exam room before they step on the field itself becomes the testing ground. And given the stakes, that is a risk we simply cannot accept.
Absolutely. Let's pivot just a bit. Let's unpack this concept of the athlete's heart that you just mentioned. Because if we look at a healthy, elite athlete's ECG, it is not going to look anything like the ECG of a normal person sitting at a desk all day.
Oh, not at all.
The heart is a muscle, and like any muscle subjected to intense daily training, it adapts, it remodels, it rewires itself.
It absolutely does.
How exactly does this electrical rewiring manifest on the diagnostic tests you look at?
The most profound and common changes we see are secondary to something called increased vagal tone.
Vagal tone.
Yes, we have to look at the autonomic nervous system. You have the sympathetic branch, the fight or flight system, and the parasympathetic branch, the rest and digest system.
Right.
The primary physiological highway for that parasympathetic signal to reach the heart is the vagus nerve.
Okay, so if the sympathetic system is the gas pedal, the vagus nerve is like the brake pedal for the heart.
Exactly. It acts as the primary braking system. In highly trained athletes, as a direct adaptation to their training, this vagal tone is massively amplified at rest.
The brake pedal's being pressed harder.
Yes. As a result, we routinely see resting sinus bradycardia, which is the medical term for a very slow heart rate.
How slow are we talking?
Well, in elite endurance athletes like competitive cyclists or Olympic marathoners, it is not uncommon to see resting heart rates drop below 35 beats per minute.
Which would usually trigger absolute panic in an emergency room.
Oh, it would.
If a normal, untrained person walks into the ER with a heart rate of 33, doctors are calling a code and prepping a pacemaker because they think the heart is failing.
Exactly. They think it's a massive block.
But for the endurance athlete, it is basically a biological badge of honor. It just means their heart is so incredibly strong and efficient, it only needs to pump 33 times a minute to supply their entire body with oxygen while they are sitting still.
Precisely. It is supreme efficiency. Alongside that profound bradycardia, we see other vagal adaptations. We see sinus arrhythmia, where the heart rate speeds up and slows down noticeably in sync with their breathing.
Okay.
We also frequently see a first-degree AV block.
Wait, block sounds bad. What is an AV block?
It sounds worse than it is. The electrical signal originates in the top of the heart, the SA node, and travels down to the AV node, which acts as a gatekeeper before sending the signal to the bottom pumping chambers.
Right.
In an athlete with high vagal tone, that gatekeeper holds on to the signal just a tiny bit longer than normal. It's a slight, completely harmless delay in the electrical transit.
Ah, I see.
Another incredibly common finding is early repolarization, which shows up as specific slurred elevations on the ECG tracing as the heart resets for the next beat. All of these are normal, highly physiological responses to rigorous training.
And it is not just the speed and the timing, it is the raw electrical voltage, right? Because the heart physically grows larger to pump all that blood. It must generate more electricity to stimulate that larger muscle mass.
That is exactly the physical mechanism. The ECG records electrical amplitude. Because the ventricular muscle masses are physically thicker, they generate a much larger electrical wave when they depolarize.
You literally see bigger spikes on the paper.
Yes. Therefore, we see large QRS voltages on the ECG. We also frequently see electrical patterns that meet the criteria for incomplete right ventricular hypertrophy, or RVH.
Okay, but is that a problem?
Here is a crucial nuance for any clinician interpreting these scans. Seeing high voltage criteria for left ventricular hypertrophy, or LVH, in isolation, meaning the voltage spikes are huge, but there are no other abnormalities like T-wave inversions or ST segment depressions, is a completely benign, normal adaptation in an athlete.
Good to know.
The high voltage alone simply means the muscle is thick and powerful. It absolutely does not mean it is diseased.
Here's where it gets really interesting, and honestly a bit tricky for diagnosticians.
Oh, the repolarization changes.
Exactly. We have to talk about the profound differences in ECG patterns based on ethnicity, specifically regarding the Black athlete's ECG. The repolarization phase, the exact part of the electrical cycle where the heart is resetting itself for the next beat, looks very, very different in athletes of African or Afro-Caribbean descent, doesn't it?
The demographic data on this is incredibly striking, and it is a major focus of modern sports cardiology.
Tell me more.
Up to 40% of Black athletes show what we call J-point elevation with ascending concave ST segments, compared to only about 25% of white athletes.
Okay.
But the most distinct pattern, and the one that historically caused the absolute most clinical confusion and panic, is seen in leads V2 through V4 on the ECG. Black male athletes frequently exhibit J-point elevation, convex ST segments, and very deep T-wave inversions in these specific leads.
Okay, let's slow down and try to visualize that, because you and I know that a convex ST segment combined with a deep T-wave inversion looks terrifying to an untrained eye.
It really does.
If we think of the ST segment as a curve, a concave shape is like a smile, dipping down and coming up. But a convex shape is like a frown, curving upward and then plunging down into a deep negative valley.
Perfect description.
If a 50-year-old man walks into a primary care clinic with a frown pattern on his ECG, the doctor immediately hits the panic button, because that perfectly mimics an acute massive heart attack.
Yes, or Brugada syndrome.
Exactly, or Brugada syndrome, which is a lethal genetic arrhythmia, or acute pericarditis, a painful inflammation of the heart sac. But in an asymptomatic Black athlete, you're saying this terrifying frown pattern is totally fine.
That is the remarkable, sometimes counterintuitive reality of physiological adaptation. In the specific clinical context of a young, asymptomatic Black athlete who has a normal physical exam and absolutely no family history of sudden cardiac death or inherited cardiomyopathy, that specific V2 through V4 pattern is considered a normal, ethnic-specific variant of the athlete's heart.
So they don't need surgery or anything?
No, it does not warrant any further investigation. Recognizing this specific variant over the last decade has saved thousands of Black athletes from being unnecessarily sidelined from their sports, subjected to expensive and stressful MRIs, and suffering the intense psychological trauma of a false diagnosis of heart disease.
But we have to be incredibly careful here, because T-wave inversions, or TWIs, are not always a benign ethnic variant.
Right, they can be dangerous.
In many cases, they can be massive, flashing red flags. How do you, as a specialist, distinguish the good, healthy inversions from the bad, pathological ones?
It almost entirely comes down to the anatomical location on the ECG and the demographics of the patient.
Can you give an example?
As we just noted, anterior TWI, meaning the inversions are in leads V2 and V3, which look at the front of the heart, is very common in early adolescence across all races. We call this the juvenile pattern, but it rarely persists past the age of 16 as the nervous system matures.
Okay, that makes sense.
We also see a statistically higher prevalence of benign V2, V3 T-wave inversions in adult female athletes and in high-level endurance athletes. However, there are undeniable red flags that always, without exception, require immediate and aggressive medical investigation.
Right, the absolute non-negotiables, where you don't just say, oh, it's probably fine.
Exactly. If we see lateral T-wave inversion, meaning the electrical inversions are in the leads looking at the sidewall of the left ventricle, specifically leads V5, V6, I, and AVL, that is never considered a normal physiological adaptation to sport.
Never.
Ever. Similarly, any ST segment depression, where the baseline sags down, the presence of pathological QAs, which indicate prior permanent heart muscle damage or scarring, or a left bundle branch block, which represents a major widespread conduction delay across the left ventricle, are absolute red flags.
So those are the undeniable bad signs.
Yes. These specific findings demand a full, comprehensive clinical workup, regardless of how incredibly fit or asymptomatic the athlete appears.
All right, here is a slightly tricky interactive question for you listening.
Yeah.
Let's say an elite athlete has an isolated short PR interval on their ECG.
Okay, a short PR.
This means the electrical signal moves from the top chamber to the bottom chamber of the heart unusually fast. It skips the normal delay. But this athlete has absolutely no symptoms, no palpitations, no dizziness, nothing. What should the cardiologist do? A, order an immediate cardiac MRI to look for hidden scars. B, stop them from playing their sport pending a full medical review board. Or C, do absolutely nothing.
The correct answer is C, do nothing.
Why do nothing?
Well, an isolated short PR interval without any accompanying symptoms or other specific pathological ECG abnormalities like a delta wave, which point to the extra pathway seen in Wolff-Parkinson-White syndrome, does not constitute pathological electrical remodeling.
And it's just a quirk.
Yes, it is considered an incidental, benign finding. Investigating it further usually just leads to a cascade of unnecessary medical tests, extreme anxiety for the athlete, and a waste of healthcare resources.
That brings us to another major turning point in our discussion.
Okay, where to?
So we spent a lot of time looking at the wiring, the complex electrical system of the athlete's heart. Now let's look at the plumbing and the actual walls of the house.
The structural changes.
Because to pump that immense volume of blood during a 2-hour marathon or a grueling 90-minute soccer match, the heart physically bulks up, right? I mean, I like to think of it like going to the gym. Just like doing heavy bicep curls, tears microfibers in your arm and builds a larger bicep muscle, intense daily cardiovascular exercise builds a larger cardiac muscle.
The core concept is similar, yes, though the biology is a bit more elegant. We call this architectural remodeling cardiac enlargement. And in a healthy, highly trained athlete, this enlargement is usually highly symmetrical.
Symmetrical meaning it grows evenly.
Exactly. It affects all 4 chambers of the heart proportionally to handle both the increased volume of blood and the increased pressure required to pump it.
Okay, let's talk numbers.
When we measure this physical growth via an echocardiogram, an ultrasound of the heart, we typically see a 10 to 20% increase in the ventricular wall thickness, alongside a roughly 10% increase in the overall internal cavity size.
And the absolute dimensions of this growth can be staggering when you look at the numbers.
They really are.
A normal, untrained left ventricular cavity, which is the main pumping chamber that shoots oxygenated blood out to the entire body, might be around 50 millimeters wide in an average adult male. But in elite male endurance athletes, you guys routinely see LV cavities balloon out to 60 or even 70 millimeters.
Yes, 70 millimeters is huge.
It becomes this massive, highly compliant reservoir designed to hold and pump massive stroke volumes of blood. But again, just like with the electrical signals, we see significant racial differences in this structural remodeling, particularly regarding exactly how thick the muscle walls get.
And the demographic data is absolutely essential here to avoid misdiagnosis.
How so?
Up to 18% of elite black male athletes will develop a left ventricular wall thickness between 12 and 15 millimeters as a pure, healthy physiological adaptation to their sport.
So 15 millimeters is normal for them?
Yes. Their hearts naturally build thicker, more robust walls to handle the sheer volume and blood pressure spikes of elite training. However, if you see a left ventricular wall thickness exceeding 14 millimeters in a white athlete, That is highly exceptional.
A completely different standard.
Exactly. In that specific demographic, a wall that thick screams pathology, specifically raising very high suspicion for hypertrophic cardiomyopathy. So the exact same millimeter measurement on an ultrasound is a perfectly normal finding in one athlete and a major, potentially life-threatening red flag in another.
I actually want to adjust my gym analogy because it's not just about a thicker bicep.
No, why is it then?
It's more like a suspension bridge. If the daily traffic over the bridge doubles, that's the exercise volume, the engineers don't just build the road deck wider. They have to reinforce the steel cables and thicken the concrete support pillars to handle the load.
I like that.
The heart is thickening its walls to support the massive volume of blood inside the expanded cavity. And it's not just the left side of the heart getting massive. The right side is doing heavy lifting too, right?
That's right.
The right ventricle is the chamber that pumps blood locally to the lungs to get oxygenated. And during extreme exercise, pulmonary blood pressure goes way up.
Indeed, the right ventricle remodels significantly to handle that elevated pulmonary resistance. In fact, our imaging data shows that up to 40% of highly trained endurance athletes have a right ventricular outflow tract diameter that is so significantly enlarged, it looks virtually identical to the formal imaging criteria for a deadly disease.
Which is
Arrhythmogenic right ventricular cardiomyopathy, or ARVC. We also see remodeling in the major plumbing itself, specifically the aorta.
the aorta gets bigger too.
The aortic root, where the blood exits the heart, can dilate to handle the massive stroke volume, though it rarely exceeds 40 millimeters in men or 38 millimeters in women.
And if it gets bigger than that?
If it dilates beyond those upper physiological limits, we stop thinking about athletic adaptation and we start worrying about dangerous connective tissue diseases.
Let's talk about how this massive, deeply remodeled engine actually functions when it is just idling.
Okay, functional changes.
Because this brings us to one of the most counterintuitive, mind-bending findings in all of sports cardiology. Generally, the systolic function, which is the active squeezing power of the muscle, and the diastolic function, which is the active relaxing and filling phase, remain completely normal or even supernormal in these athletes.
Right.
But there is a major catch when we look at their resting ejection fraction.
This is a vital concept to grasp. Ejection fraction is a mathematical percentage.
How do you calculate it?
It is the percentage of blood the left ventricle pumps out with each individual beat compared to how much it holds when full. A normal, healthy person usually sits between 55 and 70%.
Okay, sounds reasonable.
But in about 11% of elite endurance athletes, their resting left ventricular ejection fraction is actually borderline low, hovering down around 48 to 54%.
Okay, to put that strange statistic into perspective, I want to present our second practical case for this deep dive.
Let's hear it.
Imagine a 28-year-old elite endurance cyclist. He rides hundreds of miles a week. He is in the best shape of his life. But he goes in for a routine scan, and the doctor sees a massively enlarged left ventricle with a borderline low resting ejection fraction of 50%.
Okay.
On paper, a big dilated heart with a weak squeeze of 50% perfectly mimics the early stages of dilated cardiomyopathy, which is literally heart failure. So is this young world-class cyclist heart actually failing? Are his days on the bike numbered?
The answer and the ultimate clinical proof lies in the application of the exercise stress test, which reveals the magic of what we call myocardial reserve.
How does that work?
While his resting heart looks sluggish, weak, and dilated on the ultrasound table, it is simply an illusion of efficiency. The cavity is so enormously enlarged that it only needs to squeeze a very small percentage of its total volume. Just 50% to circulate enough absolute blood volume to keep him alive while he is sitting still.
Wow, so it's just coasting.
Yes. The muscle isn't weak, it's just barely working because the demand is so low. But if you put that exact same cyclist on a stationary bike in the lab and run a maximal exercise stress test, his ejection fraction will rapidly and aggressively normalize.
It wakes up.
As he pedals harder, the EF will jump by more than 10%, proving definitively that he has excellent myocardial reserve. His heart isn't failing, it is just resting with supreme efficiency.
That is incredible.
During peak exercise, he will demonstrate a massive stroke volume and incredibly high oxygen consumption. A truly failing heart in a patient with actual dilated cardiomyopathy cannot do that. Their ejection fraction will remain low or even drop further under the stress of exercise because the muscle is truly diseased.
Okay, so that perfectly covers the structural adaptations. Let's move on to when we actually need to sound the alarm.
The clinical red flags.
Exactly. We've talked endlessly about all these crazy adaptations. Slow heart rates, massive voltage spikes, huge cavities, low resting squeeze that mimic terrible diseases but are actually just signs of incredible athletic fitness. But eventually, a doctor has to decide when to stop reassuring the athlete and start actually worrying.
Right, there comes a point.
When do we actually ring the alarm? What are the specific symptoms that make a specialized sports cardiologist sit straight up and say, wait a minute, we have a serious problem here?
We look for specific clinical red flags, and it is vital to understand that the timing and the context of these symptoms are absolutely everything.
Context is key.
Let's start with syncope, which is the formal medical term for fainting or passing out. Fainting is common in the general population, but exertional syncope, meaning the athlete loses consciousness during active exercise, right in the middle of a full sprint or during a heavy, straining lift, is a massive, flashing red flag.
Why is it so dangerous during the exertion?
It strongly points to a dangerous mechanical obstruction preventing blood from leaving the heart to reach the brain, or a sudden lethal electrical arrhythmia that temporarily stops the heart from pumping entirely.
And we really have to contrast that with fainting after exercise, right?
Absolutely huge difference.
If an athlete crosses the finish line of a grueling hot marathon, stops running, takes 2 steps, and then passes out, that is usually much less concerning to you guys.
Yes, much less concerning.
From what I understand, that is often just vasovagal syncope or severe blood pooling in the legs because the leg muscle pumps have suddenly stopped moving blood back to the heart. It is still scary to witness, but the mechanism is usually totally benign.
Exactly right.
But what about chest pain? I mean, athletes get chest pain all the time from pulled pectoral muscles getting hit with a ball or exercise-induced asthma.
True, musculoskeletal pain is incredibly common, but exertional chest pain that feels deep, tight, and comes on consistently with physical effort must always be investigated aggressively to rule out cardiac ischemia, which is a lack of oxygen to the heart muscle.
But in a young kid, are we looking for clogged arteries?
Now, in a young athlete, we aren't usually looking for atherosclerotic plaque buildup. Instead, we are looking for anomalous coronary arteries.
What are those?
This is a congenital defect where the main blood vessels feeding the heart muscle are routed incorrectly through the chest and literally get pinched shut between the major vessels when the heart expands during exercise.
Oh, wow. So it just cuts off the blood supply.
Yes, or we are looking for active myocarditis, which is an acute viral inflammation of the heart muscle itself that causes pain and predisposes to arrhythmias.
That makes sense. Any other red flags?
Another major red flag is disproportionate breathlessness. If a highly trained athlete, who usually runs 10 miles with ease, is suddenly struggling to catch their breath during a simple 5-minute warm-up, that is a glaring warning sign that the heart's pumping efficiency might be suddenly compromised.
So once those specific alarm bells ring, what does the investigative toolkit actually look like? What are the primary weapons a cardiologist uses to figure out exactly what is going wrong inside the chest?
The primary tools are highly accessible and non-invasive. First, we utilize Holter monitors, which are essentially wearable continuous ECGs.
Just a little box they wear.
Exactly. We use these specifically for athletes complaining of palpitations or racing heartbeats. We are looking for abnormal beats, like premature ventricular complexes or PVCs, and we care deeply about the electrical axis of these PVCs.
The axis.
Yes, if the ECG shows they have a superior or intermediate electrical axis, it suggests they are originating from a potentially dangerous scarred area of the right ventricle.
What's the second tool?
Second, we have the echocardiogram, which is essentially an ultrasound of the heart. This lets us visualize the physical structure, measure the exact wall thickness down to the millimeter, and physically watch the valves open and close in real time.
And the third.
And third, of course, the exercise stress test, which we discussed with the cyclist. It is absolutely critical for trying to actively unmask adrenergically mediated arrhythmias or specific electrical diseases like Brugada syndrome that might hide completely normally when the heart is at rest.
But sometimes the basic ultrasound and the treadmill test just aren't enough, especially when we were trying to find microscopic scars buried deep in the muscle or visualize tiny misplaced arteries hiding behind the aorta.
Right, they have limits.
That is when we bring in the heavy artillery.
Exactly. When the clinical suspicion is high but the basic tests are equivocal, our secondary advanced tools are incredibly precise. cardiovascular magnetic resonance imaging, or CMR, is the absolute gold standard if we see red flags on the ECG, like that lateral T-wave inversion we talked about earlier.
So an MRI of the heart.
Yes. Echocardiograms can miss subtle structural things due to the ribs or lungs getting in the way, but a CMR uses powerful magnets and specific contrast dyes, like gadolinium, to detect tiny patches of myocardial scar tissue, subtle fibrotic changes, or active fluid and inflammation from myocarditis.
Just to clarify, the gadolinium dye actually gets stuck in the scar tissue, right? So it lights up on the MRI to show you exactly where the heart is damaged.
That is exactly how late gadolinium enhancement works. It washes out of healthy tissue quickly, but pools in the scarred areas, giving us a highly precise tissue-level characterization of the heart muscle.
Very cool.
We also rely heavily on CT coronary angiography. This is a specialized, incredibly high-resolution 3D X-ray scan that is the definitive key for ruling out those anomalous coronary arteries we mentioned earlier. It shows us, in beautiful 3D detail, exactly where the arteries originate and how they route around the structures of the heart.
Let's see if you were paying close attention to the specific context of those red flags we just discussed, listener.
So let's test them.
Which of the following scenarios is considered highly concerning and requires an immediate, aggressive cardiac workup? Is it A, fainting immediately after completing a long, hot, exhausting race? B, fainting directly in the middle of a high-speed, intense sprint? Or C, discovering a resting heart rate of 32 beats per minute in an Olympic rower?
The answer is B, fainting in the middle of a sprint.
During the sprint?
Yes. As we unpacked, collapsing while the body is under peak physiological demand and pumping maximum blood points directly to a catastrophic mechanical failure or a lethal electrical short circuit.
And the other two?
Post-race fainting is usually just benign blood pooling, and a 32 beat per minute resting rate is merely a sign of elite, highly adapted vagal tone. In sports cardiology, context is absolutely everything.
Let's transition to what might be the hardest part of the job.
The diagnostic overlaps.
Here is where we hit what I think is the ultimate diagnostic conundrum in sports cardiology.
Yeah.
We know that elite, vigorous physical training physically and electrically remodels the heart. It gets bigger, it gets thicker, it beats slower, it generates more voltage.
Right.
The profound problem is this exact physiological adaptation perfectly, flawlessly mimics some of the most deadly cardiac diseases known to modern medicine. It is quite literally a biological disguise.
It really is a disguise.
How on earth do cardiologists confidently tell the difference between a super athlete with a massively adapted heart and a ticking time bomb with a deadly disease?
It is undoubtedly the most challenging, high-stakes, and critical part of the job. To navigate this extreme diagnostic overlap, we break the problem down into 4 major clinical overlap syndromes.
4 overlap syndromes.
Yes. These are the specific areas where the athlete's healthy adaptation looks almost visually identical to a lethal pathology on our scans.
Yeah.
We have to meticulously, carefully separate them using every piece of the diagnostic toolkit we just discussed.
Let's take them one by one because this is fascinating. Overlap syndrome number 1. Physiological left ventricular hypertrophy, which is the healthy thickened muscle from exercise, versus hypertrophic cardiomyopathy, or HCM, which is the leading cause of sudden death in the U.S.
Right. Both cause thick walls.
Exactly. Both conditions result in thick heart walls. How do you split them apart?
We look for specific patterns of growth and function. HCM typically presents with asymmetric hypertrophy, meaning one specific part of the wall, usually the septum, is massively, disproportionately thicker than the rest of the heart.
But the athlete's heart?
A healthy athlete's heart hypertrophies highly symmetrically. Furthermore, an HCM heart usually has a strangely small left ventricular cavity size, whereas an athlete's cavity expands.
Oh, it's a big difference.
And because the HCM muscle is so pathologically stiff and disorganized at a cellular level, it has profoundly impaired diastolic function, meaning it struggles to relax and fill with blood between beats.
So it's thick, small, and stiff.
Exactly. Interestingly, while we often think of HCM causing a physical mechanical blockage of blood flow, what we call dynamic outflow obstruction, that specific feature is actually quite rare in young athletes who have HCM.
Good to know.
But the absolute biggest differentiator is the resting ECG. Over 95% of athletes with true HCM will display undeniably abnormal repolarization patterns, specifically those deep red flag lateral T-wave inversions we discussed.
Okay, overlap syndrome number 2. We actually touched on this deeply with our 28-year-old cyclist case.
The low ejection fraction.
Right, physiological low ejection fraction versus dilated cardiomyopathy, or DCM, where the heart becomes weak, thin, and floppy. Sitting in the clinic, the resting ultrasound looks identical. A huge cavity with a really lazy 50% squeeze.
Right. And as we established with the cyclist, the absolute key differentiator here is proving myocardial reserve during an exercise stress test.
Seeing if it wakes up.
Exactly.
Yeah.
The healthy athlete's ejection fraction will rapidly and powerfully surge under the stress of exercise, proving the engine works beautifully when actually called upon. The patient with true dilated cardiomyopathy physically cannot mount that response.
And he uses the MRI too.
Additionally, we use that advanced CMR imaging. An athlete's massive heart will have pristine, perfectly healthy tissue on the MRI, whereas a heart with dilated cardiomyopathy will frequently show microscopic scarring or diffuse fibrosis embedded within the stretched, dying muscle walls.
Okay, overlap syndrome number 3 is visually fascinating to me. It involves the actual physical texture of the inside of the heart.
The trabeculations.
Physiological trabeculation versus left ventricular noncompaction, or LVNC. If you look inside a normal heart, the walls aren't perfectly smooth like glass. They have these little muscular ridges and grooves called trabeculations, which are leftovers from when the heart formed in the embryo.
Right.
But sometimes this texture gets totally excessive.
It can look very dramatic and terrifying on an ultrasound. In fact, roughly 20% of highly trained athletes develop extremely prominent trabeculation.
20%?
Yes, the inside of their heart muscle looks incredibly spongy, almost like a C-sponge. And remarkably, about 8% of totally healthy elite athletes actually meet the strict formal medical imaging criteria for the disease LVNC.
Wait, so the healthy hearts look exactly like the disease?
Because of this massive, confusing overlap, the field is actively shifting its terminology. We now prefer to call the physical appearance left ventricular hypertrabeculation, or LVHT, because possessing the trabeculation itself doesn't guarantee you have the disease.
So if a staggering 8% of healthy athletes look exactly like they have the disease on an ultrasound, how do you actually prove if they are the unfortunate ones who truly have it?
True pathology is proven by looking beyond just the spongy appearance. We look for a strong, documented family history of heart failure or sudden death. We look intensely at the solid, compacted muscle wall sitting beneath the spongy layer.
So underneath the sponge.
Yes, if that solid foundation is dangerously thin, that is a major problem. And again, we look for late gadolinium enhancement on an MRI, which proves the undeniable presence of permanent scar tissue embedded deep in the heart wall.
So if there's no scar and the foundation is solid,
If the athlete just has the spongy texture but completely normal pumping function, normal ECGs, and no scars on MRI, we classify it as a benign, fascinating adaptation to extreme preload.
finally, overlap syndrome number 4. Moving over to the right side of the heart. Physiological right ventricular enlargement versus arrhythmogenic right ventricular cardiomyopathy, ARVC.
This is a tough one.
We noted earlier that extreme endurance training blows up the right side of the heart to handle pump massive volumes of blood to the lungs. But ARVC is a deadly genetic disease where the right side of the heart dilates and the healthy muscle is systematically replaced by fat and scar tissue, causing lethal arrhythmias.
Yes.
How do you tell them apart when they both present with huge right ventricles?
We look at the symmetry of the growth and the specific, highly detailed metrics of how the right ventricle functions. An athlete will almost always have symmetrical biventricular enlargement.
The ratio you mentioned?
Exactly. If you mathematically take the size of the left ventricle and divide it by the size of the right ventricle, the ratio is typically less than or equal to 0.9. They grow in proportion together.
But in the disease.
In stark contrast, ARVC is a disease specifically and aggressively attacking the right side, so the right ventricle becomes disproportionately huge and dysfunctional compared to the left.
So you look at the fractions.
We definitively ring the alarm for ARVC if the right ventricular fractional area change drops to 30% or lower, if the RV ejection fraction drops to 45% or lower, or if we see localized regional wall motion abnormalities.
Meaning parts of the wall just aren't moving.
Right, paired with the telltale presence of fatty or fibrotic scars lighting up on the MRI.
Now, a completely logical question from anyone listening to this incredibly complex, multi-layered diagnostic process is, why do we have to guess and calculate ratios with all these expensive images and treadmill tests?
Ah, the genetics question.
Yeah. If we know these diseases like HTM and ARVC are fundamentally inherited genetic mutations, can't we just swab the athlete's cheek, run a quick DNA test, and know for sure if they have the gene for the disease?
It is a great, highly intuitive question, and it is a very common misconception in the public. Yes, molecular gene panels have become much cheaper and more accessible in the last few years.
So why not just use them?
But cardiovascular genetics is incredibly, profoundly complex. The diagnostic yield of these genetic tests is surprisingly low. We simply haven't identified every single specific gene mutation that causes these diseases. The human genome is vast.
Oh, I see.
Therefore, while a positive genetic test can definitively confirm a diagnosis and help us aggressively screen family members, a negative genetic test absolutely does not rule out the presence of a lethal cardiomyopathy.
So a negative swab doesn't mean you're clear.
Exactly. You cannot rely on a negative DNA swab to clear an athlete if their clinical imaging still lists highly suspicious. The clinical phenotype, what the heart actually looks like, and how it acts always overrides the genetic test.
All right, let's take a slight turn here to discuss what happens when we do find something.
Okay, the management phase.
So let's say the absolute worst happens. You run all the tests, you look at the MRI, and the diagnosis is definitively confirmed. The athlete does have a structural cardiomyopathy or a dangerous electrical disease.
It's a devastating moment.
Historically, the medical approach to this was extremely, almost brutally paternalistic. A doctor would find a defect, sit the young athlete down in the office, and deliver an absolute life-altering edict. You have a heart condition, you can never, ever play competitive sports again, period.
That was the standard for decades.
It was a blanket ban aimed at minimizing liability for the doctor and maximizing safety for the patient. But based on the 2026 guidelines, that philosophy has fundamentally radically shifted, right?
It has shifted dramatically, and for the better. The modern 2026 approach in sports cardiology is deeply rooted in a concept called shared decision-making.
What does that actually mean in practice?
We now wholly understand that completely stripping an athlete of their sport, their identity, their community, their scholarship, their physical outlet can have devastating psychological, social, and even physical consequences.
It destroys their world.
Yes. So instead of dictating from on high, we collaborate. We sit down with the athlete, their family, their coaches, and their team doctors. We transparently and honestly balance the very specific, scientifically backed risks of their exact individualized disease against the inherent unpredictable nature of sports.
And what's the outcome?
We optimize their medical treatment with cutting-edge drugs or procedures, and in many, many cases today, we find a carefully monitored pathway for them to safely return to play.
Let's get into the granular specifics of how you manage structural heart disease under this new collaborative paradigm, because obviously some things are still too dangerous. What are the rules for who can play and who can't?
It is highly tailored to the exact pathology. Let's start with the absolute non-negotiable restrictions.
The hard bans.
Right. If an athlete has overt, confirmed ARVC, or if genetic testing reveals they harbor specific, highly aggressive, high-risk genetic variants-like mutations in the desmosomal genes, laminin AC, filamin C, or TMMM3, vigorous exercise is strictly, unequivocally prohibited.
Why such a hard line on those specific ones?
Because in these specific conditions, intense exercise doesn't just act as a momentary trigger for a sudden arrhythmia. It actively and rapidly accelerates the mechanical destruction of the heart muscle itself.
Oh, wow.
For example, in ARVC, the desmosomes, which are the microscopic biological glue holding the heart muscle cells together, are genetically defective. When the heart pumps violently during exercise, it literally tears its own cells apart, accelerating the replacement of muscle with fat and scar tissue.
So exercising actually kills the heart faster.
Playing sports will literally make the disease progress faster and kill them sooner.
Wow. Okay, that makes total sense. But that is not the case for all cardiomyopathies.
Yeah.
What about the big ones we discussed, HCM and DCM?
This is where the paradigm shift is most evident and exciting. For athletes with hypertrophic cardiomyopathy or dilated cardiomyopathy, if they are completely asymptomatic in their daily lives, optimally treated with modern medications, and most importantly, if comprehensive testing proves they do not display any high-risk clinical markers.
Meaning what, exactly?
Meaning they've never fainted, their arrhythmias are controlled, and they don't have massive scar burdens on their MRI. If that's the case, current guidelines state they can engage in a shared decision-making process to participate in most competitive sports.
That is a huge change. What about myocarditis? We saw a ton of this discussed over the last few years. Viral infections temporarily inflaming the heart muscle. Is that a permanent career ender?
Not usually, but it requires extreme patience and caution. The protocol for acute myocarditis is strict abstinence from any vigorous exercise for a minimum of 12 weeks.
3 whole months of doing nothing.
Yes. The heart is acutely inflamed and flooded with immune cells. It needs to heal exactly like any other severely sprained or torn muscle. They can only return to play after that 12-week period if their blood tests show completely normal troponin levels, indicating no active muscle damage is occurring.
And their MRI is clean.
Exactly. If a repeat CMR shows the edema and inflammation have completely resolved, and if a maximal stress test proves they don't have any exercise-induced arrhythmias hiding in the healed tissue.
And what about the anatomical plumbing issues, the anomalous coronaries, where the arteries are routed weirdly?
That depends entirely on the specific routing error of the plumbing. The coronary arteries originate from the base of the aorta at little pouches called the sinuses of Valsalva.
Okay.
If the left main coronary artery mistakenly arises from the right sinus and routes directly between the aorta and the pulmonary artery, it acts like a garden hose caught between two expanding balloons.
Oh, that sounds really bad.
It is. It gets pinched shut during exercise, starving the massive left ventricle of oxygen. That requires major open-heart surgical correction before any return to play is even considered.
But what if it's the other way around?
However, if the right coronary artery arises from the left sinus, it feeds a smaller area of the heart and is generally considered much less dangerous. If a maximal stress test proves there is no ischemia, no lack of oxygen to the heart muscle under maximum load, they can often continue to play their sport safely without undergoing open heart surgery.
Okay, so that perfectly covers the structural side, the walls, and the plumbing. What about managing the electrical diseases, the software glitches?
These are managed very differently, often with specialized procedures. For Wolff-Parkinson-White syndrome, where the athlete has an extra rogue electrical pathway, the gold standard of care is an electrophysiological study followed by a catheter ablation.
How does that work?
We thread a wire up into the heart, find the exact microscopic rogue pathway, and literally burn it away with radiofrequency energy. Once that extra wire is destroyed, they are permanently cured and can return to play completely unrestricted.
That's amazing. What about long QT syndrome?
Long QT syndrome, however, is heavily debated globally. The European Society of Cardiology remains very conservative, generally recommending against most vigorous sports.
But the U.S. is different.
Yes, large multinational registries in the U.S. have recently shown that athletes with long QT who are meticulously treated, usually with specific beta blocker medications that prevent adrenaline from spiking the heart rate, have incredibly low event rates. Many specialized sports cardiology centers now allow them to participate in almost all sports, including competitive swimming, under close observation.
And Brugada syndrome, that is the electrical glitch triggered by a high fever, right?
Exactly. Brugada syndrome patients have a genetic mutation affecting sodium channels, making them incredibly prone to lethal arrhythmias, specifically when their core body temperature spikes.
So when they get sick?
Most of their cardiac events actually happen at rest or during sleep during a fever. So they can play competitive sports, but they must strictly avoid environmental situations that cause extreme prolonged elevations in core body temperature.
Give me an example.
So they can play soccer in the spring, but absolutely no extreme ultramarathons in the desert and no Ironman triathlons where core temp goes critical.
Now, there is one final, incredibly critical category of athletes we need to discuss here.
The survivors.
Yes, the survivors of sudden cardiac arrest, or SCA. These are the athletes who actually experienced the nightmare scenario. They collapsed on the field, their hearts completely stopped, and they were miraculously brought back to life by a rapid defibrillator shock and CPR. What is their path forward?
These are undoubtedly the highest risk individuals in all of sports cardiology.
Because it already happened.
Exactly,
Okay.
because they are no longer theoretical statistical risks. They have already proven unequivocally that their specific biological environment can and will produce a fatal arrhythmia. The international consensus here is very strict, and rightly so. There is no return to high-intensity competitive sports for an athlete who has survived an SCA unless there was a clearly defined, completely reversible cause.
Reversible causes, meaning something that was a one-time freak occurrence that has been cured, like the acute myocarditis we mentioned that is now fully healed,
Yes.
or something wild like commotio cordis. From what I read, that is when a baseball or a hockey puck strikes the chest wall at the exact microscopic millisecond of the heart's electrical reset phase, sending it instantly into ventricular fibrillation.
Right, the freak timing impact.
You survive that freak accident, you wear a solid Kevlar chest protector, and you can play again because your actual heart muscle and electrical system aren't diseased at all. But what about athletes who have the disease and they get an ICD, an implantable cardioverter defibrillator? It is a specialized pacemaker implanted in the chest that can instantly shock the heart back to life if it stops.
Mhm.
Doesn't having that device make them bulletproof? Can't they just go back to playing whatever they want, knowing the device will save them?
It is a very logical thought, and patients ask it all the time, but unfortunately, no. ICDs are incredible, miraculous, life-saving devices for secondary prevention. If you go into cardiac arrest, they will shock you and likely save your life.
So why can't they play?
But they do not eliminate the underlying risk of developing the adrenaline-induced arrhythmia in the first place. The storm will still happen. Furthermore, during peak athletic exertion, the extreme adrenaline and acidotic environment in the blood can sometimes make these arrhythmias much harder to terminate,
Meaning the device might fail?
meaning the device might have to shock them multiple times. Or the device itself can physically malfunction from the impact of contact sports, or even deliver inappropriate, incredibly painful shocks because it misinterprets a totally normal high sinus heart rate of 190 beats per minute as a lethal arrhythmia.
Oh, that sounds horrible.
Therefore, athletes with ICDs are generally heavily restricted to non-contact, moderate-intensity sports like golf or doubles tennis. The device is a safety net for daily life, not a license to push the extreme physiological limits of a highly diseased underlying heart.
Okay, let's take a final deep breath and pivot to our last major topic.
The older athletes.
Yes. We focus so heavily on the young, elite, 20-something athletes. But the demographics of sports have changed wildly over the last few decades. Let's pivot and talk about the aging engine.
It's a massive trend.
We are seeing an absolute explosion of mass participation in extreme endurance events, marathons, Ironman triathlons, century cycling rides, and remarkably, 40% of the participants in these extreme events are now over the age of 40. We call them master athletes.
Right, the master athletes.
The big existential question is lifelong extreme endurance training truly a fountain of youth? Or does running 50 miles a week for 30 consecutive years actually mechanically wear out the machine?
It is one of the most hotly debated, fascinating topics in cardiology right now, and the emerging 2026 data on master athletes is revealing a deeply fascinating and somewhat sobering reality.
What are we seeing?
While these master athletes enjoy incredible muscular, mental, and metabolic health, their insulin sensitivity is perfect, they have low body fat, their hearts show undeniable signs of immense cumulative mechanical wear and tear. First, lifelong male endurance athletes have a 3 to 5 times higher risk of developing atrial fibrillation, or AFib, which is an irregular, chaotic, and often very rapid heart rhythm in the upper chambers compared to their sedentary peers.
Wait, why would running cause an irregular heartbeat in the top chambers?
Because of volume overload. To pump that much blood for decades, the atria, the top chambers, have to stretch massively. The constant stretching and microscopic tearing of the atrial tissue over millions of heartbeats literally causes inflammation and eventual fibrosis, completely rewiring the electrical pathways of the atria and making them prone to short-circuiting into AFib.
And it is not just electrical wear and tear in the top chambers, it is structural wear and tear in the pipes. The plumbing gets rusty, right?
Yes, the data on coronary calcification is alarming to many people when they first see it. We measure plaque buildup in the arteries using a specialized CT scan to get a coronary artery calcium score, or CAC score.
And 0 is good.
An ideal score is 0. Almost 20% of lifelong male endurance athletes have a CAC score over 100.
Over 100, wow.
Yes, they have significantly, demonstrably more calcium buildup in their arteries than people who exercise moderately. Furthermore, advanced MRI imaging shows that roughly 13% of these elite master athletes have actual myocardial scar tissue permanent fibrosis, specifically located in the basal subcardial mid-wall of the left ventricle.
This feels like a total massive paradox.
Mhm.
Exercise is supposed to be the magic pill that cleans out your arteries, not calcifies them and scars your heart muscle.
It is a paradox.
To figure out how to handle this mind-bending contradiction, let's look at our third and final practical case. Imagine a 45-year-old lifelong marathon runner. He is incredibly lean, his blood pressure is a perfect 110/70, he feels absolutely fantastic. But he goes in for a preventative routine scan, and it reveals a high coronary artery calcium score of 120. His arteries are literally calcified.
Right.
Does this guy need to hang up his running shoes and become a brisk walker to avoid an imminent heart attack?
This is exactly where we apply the nuance of the epidemiological data and engage deeply in shared decision-making. First, we explain to the panicked athlete why this is happening.
Why is it happening?
The physical mechanisms of running marathons for decades, the repeated massive increases in blood volume or preload and blood pressure or afterload on the heart. The literal physical mechanical bending and flexing of the coronary arteries millions of times as the heart beats violently, and the transient systemic inflammation that naturally occurs in the bloodstream after running a 26-mile race.
It adds up over time.
All of these combine to cause this specific type of calcium buildup. It is essentially an endless injury and repair cycle of the vessel walls.
So the extreme training literally causes the plaque. But is it the same kind of deadly plaque that a smoker gets?
Here is the incredible, life-saving clinical paradox.
Mhm.
Despite having high, objectively scary CAC scores, massive population data unequivocally shows that the all-cause mortality of these master athletes is still significantly reduced compared to sedentary people who have the exact same calcium scores.
Wait, so having a score of a 120 as a runner is safer than having a score of a 120 as a couch potato?
Exponentially safer. The calcium is definitely there, but the massive systemic overall physiological benefits of their extreme fitness, the fact that their coronary arteries have dilated to become huge, the fact that their bodies have built new collateral blood vessels around the plaque, their incredible metabolic efficiency seem to completely override the risk of the plaque rupturing.
That's incredible.
The plaque in athletes also tends to be denser and more stable, so no, we absolutely do not tell him to stop running. We encourage him to keep going, perhaps just optimizing his recovery and nutrition.
So what do you treat?
Our medical treatment for master athletes focuses much more on managing consequences like AFib. And uniquely, for an elite athlete with AFib, we often highly recommend pulmonary vein ablation, a minimally invasive surgical procedure to burn away the tissue causing the chaotic rhythm, rather than giving them standard beta blocker medications.
Because beta blockers literally block adrenaline, which caps your maximum heart rate. If you give a marathoner a beta blocker, they'll be exhausted walking up a flight of stairs.
Exactly. It causes profound fatigue, entirely ruining their ability to train and enjoy the sport that gives them life. We fix the rhythm mechanically so they can keep running.
Okay, final interactive bet for you listening. Let's see if you absorb the paradox.
Last quiz.
What is a known, proven consequence of lifelong high-intensity endurance training in male master athletes? A, a drastically decreased risk of atrial fibrillation. B, significantly increased coronary artery calcium. Or C, a physiological shrinking of the left ventricle.
The answer is B, increased coronary artery calcium. It is a stunning, beautiful paradox that the very activity keeping them metabolically young is actively calcifying their arteries.
It's wild to think about.
Yet, as we just discussed, the survival and mortality benefits of that exercise remain incredibly robust, proving just how profoundly complex and adaptable the human cardiovascular system truly is.
This has been an incredibly dense, fascinating journey through the literal beating heart of athletic performance. As we wrap up this episode, I want to ask you to distill this massive, complex 2026 primer down for everyone listening in their cars or at the gym right now. What are the absolute most important non-negotiable takeaways that our listeners need to remember?
If we synthesize everything we've meticulously covered today, 4 critical pillars stand out above the rest.
Let's hear the first one.
First, sudden cardiac death usually strikes without any prior symptoms whatsoever. The exercise itself is the trigger, which makes relying on a traditional stethoscope history and physical totally inadequate, and makes the 12-lead ECG an irreplaceable, mandatory screening tool for young athletes.
And the second pillar.
Second, the athlete's heart is a master of biological disguise. It undergoes extreme electrical and structural remodeling to handle the immense demands of training, and these healthy adaptations flawlessly, confusingly mimic lethal cardiomyopathies. Third, demographics dictate the diagnosis. We must mathematically recognize that Black athletes and endurance athletes possess unique, completely benign cardiovascular adaptations. Failing to recognize these specific demographic variants leads to devastating misdiagnoses and ruined careers.
And the final takeaway.
And finally, fourth, the dark era of paternalistic blanket sports bans is over. Through advanced MRI imaging and empathetic shared decision-making, we can now safely return many athletes with mild, properly treated genetic conditions back to the field of play.
We started this deep dive talking about the ultimate paradox, the healthiest bodies harboring the deadliest, most hidden secrets. We've learned today that extreme physical stress literally, physically reshapes the heart's DNA expression, its electrical wiring, and its sheer muscle mass.
It completely rebuilds the engine.
And that leaves us with a truly provocative thought to end on. If we know that exercise is this potent of a biological remodeling tool, and we know that artificial intelligence is poised to very soon integrate all these multimodal data points, your genome, your real-time ECG, your MRI, scans into a perfectly personalized predictive biological risk profile.
It's the future of medicine.
Are we rapidly approaching a future where sports cardiology doesn't just prevent sudden death, but actively engineers the exact, highly personalized exercise prescription needed to literally reverse early heart disease before it even starts? Think about how your own exercise routine might be quietly, structurally remodeling your heart right now at this very second. Thank you so much for joining us on this incredibly important deep dive into the engine of life.